me, it really makes me come alive. And and the reality is I think it's better to have that kind of attitude in general, because we can only control so many of the things that are happening. And I've come to the conclusion that pretty much what's going to happen is going to happen. And I'm okay with that, because it's game time. It's time to put on our superhero outfits and be our best versions of ourselves and take life to the max while we're here.
Okay. All right. You hear that, Dr. Burgess? No more fooling around.
No more fooling around.
No.
Go ahead.
They get to the max.
Let's be careful now. Yeah, we have to do everything. As my commander said, discretion. We'll just stick within that.
Yeah, and that's what I mean by our superhero outfits. We're going to get out there and do the right thing and help people and make an impact on people. And that's just simply the case. And we're going to do it in the most sophisticated way. The way I see it is the lectures I've been doing recently it's stuff that we already have learned, but still at the end of the day, I still have questions about like the Renin angiotensin system and how COVID triggers oxidative stress, triggers the interleukin-6 and polarization of the immune system. And so by doing these lectures, it's kind of like a way of saying, you know what, let's get it down pat, and then we're pretty much done. And then we do the next lecture like vitamin D, and we see how that ties into it. And pretty soon we start having all the puzzle pieces that really make sense, and we're not pretending to make sense. And so I will start. Nowadays, it is already established that hypertension is a modifiable risk factor for cardiovascular diseases, and reduction in blood pressure is accompanied by a reduction in cardiovascular risk. Well, by the way, this article was actually written before COVID. And so we get to look at this without any connection to COVID. So this is what they're talking about, is the connection between the ROS system leading to atherosclerosis as really the primary way that it's happening, the root of what's actually happening, versus some of the other things is just, oh, it's hypertension, oh, it's this, it's that. Well, what if it's really the renin-angiotensin system? On the other hand, the persistent burden of cardiovascular events, despite a high effective control of conventional risk factors, suggests that other mechanisms might underlie a proportion of these events. As previously reviewed by us and by others, atherosclerosis consists of an inflammatory response of the arterial wall to injuries. The inflammation is often initiated by endothelial dysfunction and progresses to cellular adhesion molecules, expression, adhesion of circulating leukocytes to the endothelial cells, leukocyte migration, and formation of a fibrous cap and a lipid core, which compromises the vascular lumen. So, okay, all basic stuff. We all know this. In addition to its traditional role in hypertension, the long-term blood pressure control system, the renin-angiotensin system, ROS, is directly involved in the development of atherosclerotic lesions due to its effects mainly on endothelial function, inflammation, fibrosis, coagulation balance, plaque stability, and structural remodeling. And so they're already looking at the ROS system as directly causing the problem. Along with the classic cascade of renin-angiotensin system, which involves the conversion of angiotensinogen to angiotensin 1 by renin, followed by its cleavage to angiotensin 2 by angiotensin converting enzyme ACE, Other peptides and enzymes related to the renin-angiotensin system are important in atherogenesis. Angiotensin 2 is the main effector. All right. So over the past 2 years, learning about COVID, realizing I was weak and I thought I knew more, but there were a lot of intricate pathways that I didn't realize. And when I learned them, everything started to make a lot more sense. And now that we've got sort of some focus points, and I really think that the renin-angiotensin system is a focus because we can tie everything else into it. And we have to, because it's the main problem with COVID and the fact that it's downregulating the ACE2 receptor. And an angiotensin 2 is dominant. The effects of angiotensin 2 are mediated by its binding into the angiotensin type 1 and type 2 receptors. So it's either going to bind to type 1 and type 2 or both in equal amounts, which would give a balanced effect. So the type 1 angiotensin angiotensin 2 type 1 receptor is the inflammation route. And the other one, the type 2 receptor, is the anti-inflammatory. So we got the yin and the yang. And that's the one thing I always look for is, for every one thing, there's the equal and opposite in the body. It has been shown that angiotensin 2 directly induces endothelial dysfunction and increases endothelial oxidative stress through the production of reactive oxygen species such as superoxide anions derived from the complex enzyme nicotinamide adenine dinucleotide phosphate oxidase, otherwise known as NOx.
You can put stuff.
Are you stepping on yours?
Somebody's
Yes, sir.
somebody's microphone is still on. We can hear you. This predominantly through the interaction with endothelial angiotensin type 1 receptor, which mediates increase in calcium concentration in endothelial cells, promoting activation of calmodulin and interaction with NOx5 calcium calmodulin binding domain. Really, calmodulin just means calcium modulation. So the angiotensin 2, if there's overabundance of it, it's going to be stimulating angiotensin type 1 receptor too much. Things are out of balance. The angiotensin 2 is not being converted to its other form, angiotensin 1,7, which would activate another receptor, actually very similar to the type 2 receptor called the MAS receptor, which is the anti-inflammatory route. So when it goes down pathway number 1, and I have a picture of this, calcium concentration goes up. And it may be that it's being released from intracellular stores, or perhaps it's a calcium channel letting calcium in. But that interaction between calcium modulation molecule interacting with NOx5, which is within the cellular membrane, triggers the production of superoxide anions. Okay, so that's where all the oxidative stress, the beginning of the oxidative stress, the cytokine storm, that's where the storm is actually starting. That's what they're talking about with oxidative stress and why we've got to buffer that, because that leads to all the other oxidative stress pathways. Activation of NOx5 mediated by angiotensin 2 produces superoxide, like the ultimate free radical, activates ROA and leads to subsequent stimulation of Rho-associated kinase in human umbilical arterial endothelial cell culture. Now, these ROA and all these terms, I always try to look them up and see if there's a way to, maybe it means something that's relevant, because I don't like to just remember, random words that have no meaning. But you'll see with all the different cellular pathways, ROA and ROC, they all sort of start with an R, and they're all a part of this ROS family. And ROS means rat sarcoma. And that was obviously named that because that was one of the pathways that they found sarcoma in when they did studies on the laboratory mice. So that's how I sort of remember that. It's probably not a good pathway. That's how I see it. Now the ROA ROC pathway, or part of the ROS family, the rat sarcoma, the BAD pathway, is an upstream regulator of mitogen activated protein kinases. And when you think of mitogen, just think of mitosis, because you'll see MAPK overexpression, or you'll see it involved with proliferation, mitosis proliferation. Now, it's not a bad pathway if it's in balance with the other pathway. Okay, so this would be the part that triggers cellular division and growth of the endothelial cells. But the problem is it's overstimulated. And that overstimulation promotes an imbalance of triggers NF-kappa B, which is a transcription factor. So everything has been happening in the cytoplasm, and then NF-kappa B gets activated, and that's sort of goes into the nucleus and triggers the transcription of various genes. And these are the ones. So NF-kappa B regulates the expression of numerous genes such as cytokines, tumor necrosis factor alpha, interleukin 6, chemokines, which is just things that attract other immune cells. So monocyte chemoattractant protein, adhesion molecules, those are there like to put the brakes. I see them as like little ropes to catch the circulating monocytes that are attracted, to grab them and pull them in. And the inflammatory enzyme COX-2, which is really just part of inflammation in general, the pathway that is blocked by NSAIDs, non-steroidal anti-inflammatories. And then I guess it does produce angiotensinogen, which can then give rise to more angiotensin, angiotensin 2, and stimulate that pathway even more. If ACE2 is downregulated or blocked. Moreover, activation NF-kappa B seems to be an important signal transducer. A signal transducer, I found it fascinating. It just means it's one form of energy is being transferred to another form of energy and amplified. So it's literally just like if somebody plays a guitar, there's the wires that connect to the speaker, and the sound that comes out, you could say that the speaker is the transducer. So it's taking the signal from the electric guitar and changing it and amplifying it at the same time. And this causes an upregulation of oxidized low density lipoprotein mediated angiotensin 1 expression. So it basically the receptors, it triggers the receptors to oxidize circulating low density lipoprotein. That's or the LDL that is gets in between the endothelial cells and embeds itself in the intima of the vasculature. It is likely that TNF alpha released upon angiotensin 2 stimulation of the angiotensin type 1 receptor in combination with interleukin 4 acts as a paracrine molecule, inducing selective adhesion of mononuclear cells to the arterial endothelium through increased expression of CAM and release of varied chemokines involved in the recruitment of mononuclear cells. So what's new? The common theme here is TNF alpha and interleukin 6 actually is the bigger thing. And we may get to interleukin 4 as well. I believe interleukin 4 triggers the T helper cells to polarize towards Th2. Okay, so that's important because then if you imagine a COVID infection, you've got interleukin 6, which is going to polarize the T helper cells, or at least the Tregs will polarize towards Th17. And so you have two different kinds of T helper cells. You got the Th17 helper cells and the Th17, and the Th2 helper cells. And they get activated. They start off as naive and they get triggered by those specific interleukins. Okay, so I'm just going to blow this up a little bit. So we've got basically two sides of a coin here. On the left, we have angiotensin type 1 receptor, and on the right, we've got the angiotensin type 2 receptor and the MAS receptor. And at first I was confused when I looked at this. I'm like, well, if angiotensin 2 binds to both, well, why would one be more dominant? Well, the answer is because if ACE2 is suppressed or blocked, say by COVID or for other reasons, then angiotensin 1,7 will not be created to interact with the MAS receptor, and apparently it also triggers the ACE2 receptor. And so if you're not getting that stimulation, then you're going to have an overabundance of angiotensin 2 stimulating the type 1 receptor in relation to the MAS receptor, which is not being activated. So again, we've got on the left side, all the bad stuff, endothelial dysfunction, cytokines, TNF alpha, interleukin 6, interleukin 4. We've got the chemokines attracting the monocytes, that will present to the naive T cells. We've got the adhesion molecules, oxidative stress, superoxide anion, recruitment of mononuclear cells, osteopontin. I see that as sort of like a bridge builder. When a plaque is being formed and the mononuclear cells are invading the space along with oxidized LDL, osteopontin sort of creates the structure that holds everything together. Sort of, and osteo means, obviously, osteo literally means bone, and pons actually means bridge. So that's how I remember it. And you can think of it as the pons of the midbrain, or I'm sorry, of the brainstem is sort of the bridge between the brain and the spinal cord. I won't say all the other stuff, but everything on the right side is the opposite. Just notice that there is nitric oxide is increased, and that's relevant to this whole system. Okay, so moving on, angiotensin 2. This induces the expression of osteopontin, a multifunctional protein found in many cell types, including macrophages, endothelial cells, smooth muscle cells, which is part of the vasculature, intima, and epithelial cells. Angiotensin 2 also upregulates the LOX gene, and I believe the LOX gene that's what really is upregulating the receptors that oxidize LDL. LOX is a transmembrane glycoprotein that serves as a receptor for oxidized LDL, or it attracts them and brings them in. The endothelium binding of oxidized LDL and LOX causes increase in leukocyte adhesion molecules, activates apoptosis pathways, and increases reactive oxygen species and induces endothelial dysfunction. So the way I see it, in the extreme cases, you might have apoptosis. For example, like with COVID in the lower lungs, you're having in the microvasculature, you're having apoptosis, destruction of some of the endothelial cells. And apparently that causes a release of von Willebrand factor into the microvasculature, which may be responsible for all the microclotting. So this, this is why I like this. It's starting to tie things together. How do things relate? According to experimental and clinical data, ACE inhibitors and ARBs, the angiotensin receptor blockers, appear to have beneficial anti-atherosclerotic effects. It has been shown that the angiotensin receptor blocker, olmesartan, significantly reduced vascular inflammation in hypertensive patients with a significant reduction in serum levels of many inflammatory markers such as C-reactive protein, TNF-alpha, interleukin-6, and the monocyte chemotaxis protein. So all of those things really, I mean, it's blocking that type 1 receptor. So it's inhibiting that effect of the angiotensin 2, leading to that whole cascade of events triggering oxidative stress, apoptosis, NF-kappa B. The first evidence of a relationship between ACE2 and atherosclerosis was demonstrated in 2006. So not that terribly long ago. 2008 found ACE2 overexpression on aortic plaques attenuate the progression of early lesions in rabbits that underwent that had endothelial injury and received an atherogenic diet, probably by conversion of angiotensin 2 to angiotensin 1,7. And so the plaques may have, I'm not sure if they induced the ACE2 overexpression or the vessels were trying to produce more ACE2 receptors in order to try to balance everything. Likewise, overexpression of ACE2 and ApoE knockout mice attenuated atherosclerotic lesion size and improved endothelial homeostasis, at least in part through a mechanism that involves reduction of angiotensin 2 induced reactive oxygen species generation. Now, ApoE, now that's a whole, I got back into looking at some of these concepts, and that's a whole nother system. And, they're involved with, I guess, binding to some, cholesterol. And in this situation, if it was knocked out, it led to an overexpression of ACE2, and then the atherosclerotic lesion size improved. Okay, so there's a direct correlation between ACE2, increased ACE2, and improvement of atherosclerosis. The protective role of ACE2 on atherosclerosis was also supported by the use of ACE2 deficient mice model ACE2 knockout. ACE2 deficiency in both LDL receptor deficient mice and ApoE knockout backgrounds resulted in larger atherosclerotic lesions when compared to their respective controls. So what they're saying is that the biggest thing here is not the LDL, it's not ApoE and, as a carrier of LDL and other cholesterol molecules. ACE2 is the biggest thing. And so that means a lot. 2008, it was demonstrated the presence of ACE2 in humans. They detected ACE2 protein in human veins, healthy and atherosclerotic arteries expressed in endothelial cells, smooth muscle cells, and macrophages. Well, that's relevant because that means then that COVID can invade macrophages and it can invade smooth muscle cells. I don't know what the relevance exactly is with that, but that's significant. In 2016, it was found that baseline circulating ACE2 activity was enhanced in chronic kidney disease patients with atherosclerotic plaques when compared to patients with no plaque, suggesting that higher circulating ACE2 activity is associated with higher risk for silent atherosclerosis, meaning that the silent atherosclerosis is in the process, and the cells are trying to produce more ACE2 receptors in order to create homeostasis. And some of those receptors end up in the bloodstream. I guess they're cleaved, or, I don't think they even mention why, but the elevated level indicates that the body's trying to get back into homeostasis by producing more ACE2 receptors. ACE2 is an integral cell membrane protein that can undergo cleavage or shedding and release its catalytically active ectodomain into the surrounding milieu. So there it is. It is cleaved, it's shedded, and perhaps it's trying to bind, in a sense, other angiotensin 2 in circulation. Stop it before it even gets to the cell. The main promoter of ACE2 shedding is a disintegrin and metalloprotease, ADAM17. And, I just sort of remember these things as, look, it's disintegrating something, therefore it's, cutting something off and a receptor. And that's really how I remember that. So that might be upregulated and then causing those ACE2 receptors to shed and maybe bind some of the other milieu, bind up some of that angiotensin 2 before it gets there. Some therapeutic strategies for atherosclerosis targeting ACE2 have been thought of either with new drugs or drugs already used in the clinic. A recent study has demonstrated that the overexpression of ACE by plasmid-mediated transfection in both primary monocytes and THP1 cell. THP1 cells are basically the monocytes that they study in vitro. It's just another name for them. Leads to a marked decrease of ACE2 messenger RNA expression and induces a pro-atherogenic phenotype with elevated gene expression of the cellular adhesion molecules, ICAM, DCAM, and macrophage colony stimulating factor. And that says something. So they had a plasmid mediated transfection that decreased ACE2 messenger RNA expression. So looked like they could create some sort of infection that could manipulate this system. All these effects were partly reversed by captopril and losartan. It's interesting, and these are just facts. When I looked at losartan closely in regards to COVID, this was later in 2020, right at the beginning of the year, it was actually before the beginning of the year, they had taken losartan off the market and other ARBs because they discovered that a batch was causing cancer or could cause cancer. So it was unfortunate because that could have maybe have helped a lot of people. Anyways, in that context, this is in 2015, they showed that losartan inhibited the evolution of atherosclerotic plaques in high cholesterol fed rabbits, as well as increased the ACE2 protein expression in plaques. So, I mean, it's doing all the right things. And that's in cholesterol fed rabbits. So again, it's the issue is ACE2 and angiotensin 2. ACE2 activating drugs seem promising with emphasis on diminazine. Okay. Dyes, which has several protective effects, such as improvement of metabolic profile and reduction of lipogenesis in mice, antihypertensive effects in renal, vascular hypertensive rats, and improvement of pulmonary endothelial function in Sprague-Dawley rats. Now, the cool thing is, I just did a lecture yesterday on vitamin D, and guess what? Vitamin D actually upregulates ACE2. So the question is, do we really need diminazine, or can we just optimize our vitamin D? And you'll see that vitamin D does basically the reverse of everything that COVID is doing for the most part. Vitamin D it's all of its actions work against COVID on many different levels. Angiotensin 1.7 was investigated 3 decades ago as an important counter-regulator component of the Renin angiotensin system, promoting hypotension and bradycardia after microinjection in dorsal motor nucleus of the vagus. So this was 3 decades ago. They were testing angiotensin 1.7. Well, we have a peptide called dihexa. That's what it is. And so dihexa would be another way to balance out the renin angiotensin system and perhaps help reduce blood pressure. The formation of angiotensin 1.7 in vascular endothelium was first identified by using human aortic and human umbilical vein endothelial cells. Robust studies have shown that angiotensin 1.7 induces the MAS receptor that we saw on that slide, a G protein coupled receptor. There's only like 4 types of receptors, and G protein coupled receptor is one of them. PIK, AKT pathway, leading to phosphorylation of endothelial nitric oxide synthase. So how to really remember that? That's phosphoinositol. That's what the PI stands for, and kinase is just sort of part of the passing on of phosphorus, from one molecule to another that has a higher affinity, kind of like the electron transport chain. I remember PIK because the cell wall, the reaction is happening really in the cell wall, and phosphoinositol is it's linked to the cell wall. Is a phospholipid. Okay, so that's kind of how I see it, and otherwise I don't really have any other way to remember. But it is the good side of things in this situation, and it's leading to activation of nitric oxide synthase producing nitric oxide, more nitric oxide, and that is having an inhibitory effect on NF-kappa B. So it's balancing out what's going on with the other side of things. Angiotensin 1 is able, 1,7 is able also to promote angiotensin 2 receptor endothelial activation, which stimulates the bradykinin nitric oxide cascade. Nitric oxide is one of the most important factors released by the endothelium. So it's contributing to, so it's working alongside the MAS receptor. This gas is involved in vascular homeostasis, and its decrease induces endothelial dysfunction, which is the key factor in atherogenesis. So it's playing more of a, it's more than just, you know, when you think of nitric oxide, I mean, for me, it was just vasodilation. But when you realize it has more to do with homeostasis on the intracellular level, then I'm seeing it more like a communication signal. I'm seeing it differently. I think I already, no, I guess this is, might be, okay, studies have demonstrated that angiotensin 1,7 stimulates endothelial cell function restoration by increasing nitric oxide bioavailability. Angiotensin 1,7 downregulates the, you know, it's having the opposite effect, downregulates ICAM, BCAM in the endothelium by preventing both the phosphorylation of P38 MAPK and expression of, again, NF-kappa B. So it's just blocking that whole pathway. Moreover, angiotensin 1,7 induces proliferation of endothelial progenitor cells in the injured vascular tissue triggered by atherogenesis. So it's already blocking all of the proliferation and the formation of the plaque. During the vascular inflammation, many cytokines and inflammatory cells are required to begin and maintain atherosclerosis progression. So we know that there's all of these things that are happening as a result. In this context, angiotensin 1,7 has been described to induce anti-inflammatory phenotypes which contribute to restrain vascular lipid accumulation. And that's, I mean, that's really the name of the game. In contrast to angiotensin 2 induced proliferation and hypertrophic effects, angiotensin 1,7 inhibits the migration and proliferation of vascular smooth muscle cells. So you don't have all of the smooth muscle cells sort of, you know, closing in on that area. This effect was described in 2013, showing that angiotensin 1,7 induces activation of the MAS receptor and, you know, JAK-STAT pathways. Just remember MAS. I think that's just the most important part leading to nitric oxide in vascular smooth muscle cells to mitigate the atherosclerotic plaque formation. So that's actually happening in the smooth muscle cells. Okay, so not the endothelial cells. So it's stopping. Well, let me look at this again, showing that angiotensin 1,7 induces activation these pathways in vascular smooth muscle cells to mitigate. Okay, to mitigate. So it's stopping all the migration. Furthermore, angiotensin 1,7 has demonstrated a potential to negatively regulate the vascular fibrosis, as can be noticed by decreasing in matrix metalloproteases in atherosclerotic plaques. So it's reducing the fibrosis. And that's kind of part of what the metalloproteases do. Accordingly, angiotensin 1-7 treatment promoted a reduction in the neointimal layer growth by structural recovery of endothelium and showed atheroprotective properties attributed to the binding to both angiotensin type 2 receptor and MAS receptor. So, I mean, it's actually leading to healing. Angiotensin 1-7 reduced. So again, so I'm thinking we need to keep looking at dihexa, because if that's angiotensin 1-7 and it's reducing all these things, well, I can't think of, to me, that would be really relevant. And that's just my conclusion. It just makes sense to me. That's the logic. Why would we not be using dihexa as part of our balancing act? Because we're trying to create homeostasis. And if the root of our problems now stem from downregulated ACE2 receptors, well, we need to address that directly. We need to look at vitamin D and make sure that our levels are optimal, not just a little bit above normal, because that's going to upregulate ACE2. And then throw in dihexa. And, I think peptides, they get used as they're needed. And if we don't need them, then they don't use them. And then if that's going to stop the polarization of the immune system towards Th17, which leads to autoimmunity and cancer, well, this is why I'm going through this stuff again. I mean, it's kind of, honestly, it's a little bit painful to go through this in this kind of detail, but it leads to a conclusion that we need to address these components of the renin-angiotensin system, and we need to realize that we have tools already that we can use to do that. And of course, buffer the redox, and it's good to have something, especially with all these viruses happening all at the same time. It seems like I take methylene blue 5 milligrams twice a day, and then I take more when everybody's getting sick around me. And then I've got a wrist red light with an intranasal connection, and if I feel like I've been exposed that day, then I take my methylene blue, and then 45 minutes later I do the wrist light, which absorbs into the radial and ulnar arteries. So anything that passes there that's stained by methylene blue is going to get zapped. And the nose right now seems to be colonized quite readily with Omicron. It seems as though it causes headaches. And so, and what we could do, we do have a spray, methylene blue spray that we can use, or we've got the methylene blue, the oxytocin combination that we can spray. And then, if we review the oxytocin pathways, those are also counteracting COVID in many different ways, and creating homeostasis, and also increases the mucus layer secretions are increased. It's reducing sympathetic tone, increasing parasympathetic tone, and all these things make it more difficult for COVID to get inside our bodies. And I'm at the point now where I think, well, the name of the game is to prevent COVID, in my opinion, because every single time, at least for me, every time I get it, even if it's like, oh, it's just a cold, I end up right back with the fatigue, and nothing good comes from this infection. It's like every time we get infected, we get knocked down another level. So what if we could actually just be the people that don't get it? Everybody else gets it, but we don't, because we've got all of these different modalities that are very specific now. Talk about not shooting in the dark. Well, we know exactly why we're doing what we're doing. We're taking dihexa to counter-regulate the overabundance of angiotensin 2 to heal any atherosclerotic plaques, but at the same time to buffer any of the negative effects that COVID is going to have in triggering oxidative stress and polarizing the immune system in the wrong direction. And then upregulating the ACE2 receptors so that angiotensin 2 can convert over to angiotensin 1,7 in concert, working with dihexa as well to ensure. Then we've got a reason to actually check our vitamin D levels and actually make sure. Just taking 5,000 units of vitamin D probably isn't going to do it because it might not be absorbed. If you're in the north, if you're north of the 35th latitude, 35th degree latitude, which is anything above the northern border of Georgia or the southern border of Tennessee or the border of Arizona, California, and Nevada. Once you go north of there, you're getting less and less sun and less vitamin D photosynthesis. Yeah, just like the plants, we photosynthesize it. And that's a very energetic molecule, as I have learned to understand. And one of the things it does is upregulate ACE2. And it does other things. It enhances autophagy of all things. It turns on autophagy, especially within the immune system, so that when the immune cells phagocytose the virus or the virus gets in, it can be quickly degraded by autophagy, perhaps even before it inhibits autophagy. I don't know exactly what the virus is doing, but I do know that enhancing autophagy may help clear the virus so that it's not sticking around. Theoretically, that would make sense. In addition, angiotensin 1 reduced that atherosclerotic lesion by decreasing collagen accumulation through activation of angiotensin type 2 receptor. So apparently there's collagen over, too much collagen. Conversely, it was described an increase in collagen content after angiotensin 7 administration, resulting in the increase in plaque stability. Interestingly, increase in plasmatic angiotensin 1 has been involved in regulation of lipid metabolism. And perhaps it's decreasing inflammation, and that perhaps inflammation is what triggers more release of or creation of different lipid particles from the liver. It promoted a reduction in triglycerides and cholesterol levels, together with a decrease in adipose tissue mass, as well as an improvement of glucose metabolism. That's a lot. The authors have suggested, and they're not talking about dihexa, they're just talking about, and if you could give angiotensin 1,7. Yeah, they suggested an involvement of adiponectin in the regulation of glucose and lipid metabolism induced by angiotensin 1,7. I don't know exactly how it does that. I'm not sure if it's the endothelial cells would be producing adiponectin, or angiotensin 1,7 is having an effect on fat cells. That one is unclear. I apologize for that. Some therapeutic strategies have been validated to positively modulate the renin-angiotensin system Statins, we all know these, have emerged due to its pleiotropic properties, demonstrating additional effects apart from those of decreasing cholesterol levels. Treatment with, now this is the article, none of this is me. I'm just interpreting what I see. Treatment with statins such as atorvastatin have promoted an upregulation of ACE2 angiotensin 1 axis, reducing the proliferation of vascular smooth muscle cells and intimal thickening, respectively, effects that are closely related to atherogenesis. Well, there you go. Well, we've got other strategies. If we don't want our patients to be on statins, for various reasons, well, we've got other ways to upregulate the ACE2 angiotensin 1 axis. The role of statins on the renin angiotensin system components also have been observed in clinical trials, as shown in 2014, for the first time, an increase in angiotensin 1.7 level in hypercholesterolemic subjects after atorvastatin treatment. Altogether, those responses suggest an important role of statins on the renin-angiotensin system components, including a decrease in angiotensin 2 and apparently an upregulation in the ACE2 angiotensin 1 axis. So also decrease in angiotensin 2. This fact could be crucial to atherosclerosis and cardiovascular diseases therapy. Now, I thought I had another picture. Actually, no, we actually, I'm not sure if we saw. I'm going to see if I have it here. Give me a quick second. Okay. So let's see if it's hiding from me. Okay, it's kooky here. Just saw it. Yes. Okay. All right. So this also gives us a look at the, you can see on the right side, all the good things that are counterbalancing the production of nitric oxide, which blocks the NF-kappa B and the MAPKs. Okay, but you also get a chance to see how the oxidized LDL in the intima gets phagocytosed by the macrophages. The monocytes that come to the area get brought into the intima, turn into macrophages and ingest the LDL, oxidized LDL, and that forms the foam cells. And I don't know if that just makes it expand, but that's literally what's happening to the LDL. Yeah, it's also showing that there's the angiotensin 1 and MAS receptors in the smooth muscle cells, and the angiotensin 1, prevents them from migrating and proliferating or enclosing in. Other things that are important to notice, again, is you see the production of, or the transcription activated by NF-kappa B of interleukin 6, and it doesn't have the interleukin 4, but just know that that's the reason why acute COVID polarizes the immune system to Th17 and Th2, and we need Th1 because that's what activates or causes the differentiation of CD8 cells, and because we need CD8 T cells to kill the virally infected cells to get rid of the virus, and so the virus is making it so that the immune system thinks it's fighting something else, fighting a bacteria, because Th17 leads to neutrophilia, and so hopefully now, and we're at the end of this lecture, hopefully now, if you weren't clear yet, that you're more clear, because it really is as complicated as these pathways can be. It's really straightforward. It explains exactly what's happening, and then what can we do about it, and by buffering the redox, perhaps with methylene blue and with other modalities, and by considering dihexa, which is something I do, and also at the same time making sure our vitamin D levels, probably through the use of cod liver oil, and that's been mentioned in the articles because it absorbs we're able to absorb that better. You'll see, and I will, if you want me to, I'll do the lecture on vitamin D. And again, it's because, and I guess I can only speak for myself. Every time, if somebody were to ask me, well, how does vitamin D actually work? I would have to give like a superficial answer. Oh, it's anti-inflammatory. But that's all I understood after all these years. So I finally just dug deep with it and actually made sense of it. And it ties in nicely to what we talked about today. And you'll see how it produces cathelicidins that can punch holes in bacteria. You'll see how it can block viral entry into cells, how it triggers autophagy, how it by upregulating the ACE2 receptor, it's modulating the entire renin angiotensin system, and so yeah, and it's, now I got it, I understand it now, and so I'll do a lecture on that if you guys want. But with that, any questions?
Well, thank you so much, Dr. Joseph.
Sure,
Great
my
as always.
pleasure.
Let's see, in the chat here, where to get to?
Most excellent. Thank you, Dr. Joseph.
Thank you. Yeah, no, I hope at least there are a couple, something clicked, or maybe it, like it really created oh, now I got it now, or.
You know what? I think tonight was your Martin Luther lecture. You nailed it on the door. And you have established the truth, and thank you very much. It was wonderful.
Thank you. Appreciate that.
You want to elaborate on that one, John?
And he's putting it together. I've been watching Dr. Joseph for a while, and darn if he really didn't honestly link some very important things. And if you're watching the television or the news or sports broadcast, you would understand how important what he's, we're seeing people dying by the thousands from angio problems. And we all know what that's about. And then it was in the news yesterday when a football player went down, and the truth is creeping through. And what Dr. Joseph is doing is telling the truth. It's just appreciated and important.
All right. You know what they
Yeah,
say
and,
about,
and
Go
yeah,
ahead.
and then I was gonna say, the vitamin D lecture, they do talk about its effects on the cardiovascular system and its anti-inflammatory effects, which may have a protective effect on some of these sudden issues that are happening. I don't have. I'd have to look at it a little bit more closely, but there may be a protection aspect involved. But again, the vitamin D levels have to be optimal, not, and if we don't know. And I was going to say that John Schwartz, he did his lecture on the, on the supplements. And, he's a sales guy that understands, a level of the products. I've dug in deep into the products, looked at the data, studies. It makes sense to me because part of our issue is not absorbing vitamin D and not getting enough sun. But what are you going to do? I mean, it's freezing up here in Chicago, run around naked in the middle of the winter. And so carotenoids, vitamin A, they do make sense. There's some gene regulation, mitochondria upregulation, activating of certain genes that are favorable. I like to go in and take a second look at these and just kind of like the angiotensin or the renin angiotensin system, get it a little bit more precise, but the message is still the same. Vitamin D is a big player because it does all the opposite of what COVID is doing. But it's the absorption is the main issue. So carotenoids, vitamin A, cod liver oil, all make sense in that respect. Right now, I'm just doing the cod liver oil and doing injections, but I did do the supplements, and that's something that's measurable. You can actually measure that. And I wonder too, and there may be a connection because the carotenoids, they build up in the skin, and there was literature that skin health improves. Well, as we age, our skin thins and produces less photosynthesis of vitamin D3. Okay, so there may be a connection there. And I say that because everything I do, any supplement I take, I want it to be extremely relevant. I don't want to just, take this, take that. We've got to be different. We have the opportunity to be different, to know exactly what we're doing and why we're doing it. And as Dr. Halasa says, not shooting in the dark, I think gives us an incredible advantage. But even with the supplements, I think it's a good idea to really have that realization, like, okay, that's why I'm taking the carotenoids. Okay, now I get it. It's because the skin, and I need more absorption of the sun and photosynthesis, because vitamin D is doing all of these things. In fact, it's even modulating or creating homeostasis in our skeletal system, which is really what they call osteoimmunity. Because if your skeletal system, if your bones are getting weak, you can imagine like the trabeculae on the inside are becoming hollow. Well, what do you think is going to happen to your bone marrow, the originator of your immune system? Well, it's going to stop replicating to a certain degree. And so then you have immunosuppression on top. And that's exactly what, if there was a motive behind, polarizing of the Th17, moving everything away from T cell immunity. Well, if you throw on top of that immunosuppression at the same time, well, you're just you know, on your way to bad things. So if we think sort of bigger with and using the modalities that affect, we can't take 1,000 things. So if we take, a handful of things that are all relevant, they're all handling all the different pathways and everything that's most relevant, or it upregulates something that has an effect on all the other systems. That's the place where I'm at now. And that's the place where I like to be confident when, for anything I do, I don't want to take something just to take it. Oh, it sounds good. I want it to fit the piece, put the pieces together of a grand picture. And then, that gives us the advantage so we can think clearly and not go down the bad road. Because what I see, talking to most people that are oblivious to any of this stuff, is they're just leaving everything to chance, essentially. And every time I turn around, somebody's got cancer. It's my mother up in Michigan. They have tons of cancer, and like every time they turn around, somebody else has cancer. And why leave things to chance? So that's the purpose. That's where I'm coming from. Any other comments?
I have a comment.
Sure. Hi.
Hi. So I was thinking that perhaps taking inositol 500 milligram capsules would help to upregulate the phosphoinositol kinase that will work in the cell wall, and it will help to build the nitric oxide synthetase, and it will inhibit the NFK beta.
Yeah, exactly. So is there is this just is this sort of speculation?
That is an insight.
Okay.
I just have.
Yeah, well, yeah, I've never known what inositol really did, but I wonder if it has something to do with helping to upregulate the MAS pathway, and because of the PIK enzyme kinase, upregulate that, leading to more. And I think that those are the things I like to look at, because every time I turn around, then it brings up questions like this. And then I go on PubMed, I look up inositol, and sure enough, I wouldn't be surprised if something shows up there. Now, I try not to get caught up in one molecule, because there's probably multiple molecule supplements, I guess. So I always, then if I'm taking a supplement that has, a multi things in it, then I'm looking to see if it has inositol. And if I see it, then it's like, okay, well, now we're even adding more good things, for all the right reasons. And it will give me at least the logic behind, reinforce why I'm using a supplement. So if I can find multiple reasons that, other than just a bunch of stuff in it, and I don't really know what, I don't know for sure what it's doing. Yeah. So I'd like to look into that.
Thank you.
Yeah. And then yesterday you had mentioned the vitamin K, right?
Correct.
Is it? Yeah. No, that was great, because we talked about that afterwards, and I just wasn't aware, but the fact that it reduces calcifications, like literally, we were talking about it in the context of, what if What if he had too much vitamin D? Could it contribute to calcification since it's involved with calcium homeostasis? But yeah, I mean, the fact that you say if you had fibrocystic disease with breast disease with calcifications and vitamin K, a good supplement by itself can literally almost like bind to that calcium or bring it out. I don't know exactly how it does it. That's a big deal.
Yes.
So yeah, so that's another one for myself. Just have to gotta look it up and read it, because I'd much rather, it's a pain sometimes. I mean, I like doing it. It's just the language sometimes of you can get twisted up in some of the literature, but I always find that if I just stick with it, I can come out the other end with a nice, clear understanding. And I try to break things down to basics and tie it and see the commonalities, because I think there's a basic method to all this at the same time. It's just that the language gets confusing. But that's how I go about these things. I go through an article and then I find out, oh gosh, I really don't know this, or maybe they're talking about something that's a component, and then I've got to go look it up. But in the end, I'm telling you, it's clarity. Actually, things become more clear, and then I don't feel like I'm pretending to know things. And again, if I had to think about how I was pre-COVID, I probably did more pretending. I mean, I had intuition and I knew what I was doing, but I couldn't give you any deeper precision. And I'm convinced now that that's what we're supposed to do. We're supposed to be. Who else? If we're not going to do it, who else is? And I think this is the way doctors have used to always be. But I think the system has caused us to become, especially the newer physicians, they're becoming protocol jockeys, and they can't question the protocols because they don't have enough time to really dig into the literature and draw their own conclusions.
Yeah, I remember many years ago, or not so many years ago, I was in practice, and I was the director and the founder of the Women's Wellness Institute in Bethesda, Maryland. And I was seeing many patients, and I also had become a naturopathic doctor because I was trying, like you, to understand the basis of how people get sick and how to get rid of whatever it is they have through nutrients and through vitamins and through natural interventions. And I was an OBGYN, so many patients came to me who were seeing other doctors, and including patients with cancer who were survivors. And some of them were taking inositol. And I was always wondering, why is this patient taking inositol? And another doctor had prescribed it for cancer, but also inositol causes the nitric oxide to go up, so it's beneficial.
Interesting.
And then other patients came with taking the vitamin D, but also taking the K grouping, and they say the K, I'm supposed to take it alone, not with the other vitamins, because it works better when it's taken by itself. So I sort of acquired the experience that these patients share what other
Mm.
doctors said. But also, I have been trying to figure out on my own. And during the past years, I never had a group to ask questions to, right? I was doing it on my own. And right now, with this group, it is possible to find like-minded physicians and just come to a consensus of why do we do what we do.
So the pieces of the puzzle are coming in faster. You know, if you have some of the pieces, and then me or somebody else throws some more pieces, and then suddenly they start
So we figure
clicking
it out.
together.
Exactly.
100%. And the other reason why we have to be more precise is, you know, these patients now, at least the ones that I attract, then they have multiple things going on. Imagine there's some mold toxicity. There may be a secondary chronic viral infection. There's COVID, and then there's influenza.
Heavy
There's an
metal toxicity.
It's exactly, and so when you have multiple things going on, then you have to have this. To me, you have to have these things mastered, because then it's then you're thinking in terms of well, this is causing that, but this is causing that, and how is it overall affecting things? Because certain things will polarize the immune system in one direction or polarize it in another direction. So far, for now, the lymphocyte map has been big. I mean, it shows exactly where your immune system is polarized. And then of course, besides treating the underlying condition, because people, and this is where I think where the peptides have their place, because if the body's overwhelmed or there's too much chronic disease to the point where providing it with all of the nutrients, appropriate nutrients that it needs, still does not allow it to reach homeostasis, then we can directly push some of the buttons with peptides. And we can use thymosin alpha, thymosin beta, ARA 290, and other modulators to upregulate a part of the immune system that is downregulated, and create immune balance that way, which will ultimately reduce inflammation, which will break the cycle or reduce Th17 polarization, which can become amplified. It can turn into a wildfire and not only produce more autoimmune disease, but that's really, according to one of the articles I presented, and I may have to present it again, is really the true reason for cancer, along with the genetic component predisposition, but it's that amplification of that interleukin 6. Really, it's called the interleukin 6 amplification, and that basically what you're having is a double stimulation of MAP, or the mitogen, or the MAPK pathways, and NF-kappa B pathways, and that what starts to happen is if there's any dysfunction within those pathways, there's going to be disruption there's going to be a change in cellular division, and that's going to lead to cancer, or you could say the adaptation of the cells to a hostile environment. When you think about it that way, well, it changed, to me, it makes more sense, because now it's going to survive better with less oxygen, more oxidative stress, and I do think that there's probably, it seems like an intelligent process. So it's not, I don't see very many accidents in the body anymore. So knowing that that's where things go, well, then we need to have a map so you can see where you stand. And that again, it goes to, are we going to just leave everything to chance, or are we going to know where we stand for ourselves and for our patients so that we can address the issues? Again, having a clear understanding of where the dysfunctions are and why we're doing what we're doing. Ultimately, and I like how Dr. Halassa says it, there's really three main things at the end of the day we're trying to do. We're trying to buffer the redox. That's on the chemical level. We're trying to create immune balance, because if we don't, again, if it's Th17 polarized, it's going towards cancer. And we are trying to optimize mitochondrial function. And either one of those will affect, if you optimize mitochondrial function, you decrease oxidative stress. If you improve immune function, you're going to optimize the mitochondria. You'll have less inflammation, less oxidative stress. So that's another sort of lens I kind of look through when I'm treating somebody. Usually it's going to be one or two things to start. And it's like, well, if anything, I know exactly what I'm treating, and am I addressing those three things at the same time? Because that's sort of like the three overseers of all these. That's the biggest picture. If we have those in balance, we're healthy. I mean, nothing's going to happen, the way I understand it.
Mhm.
Any other
There's a
questions?
Couple of questions in the chat. Could Atherosclerotic, Tecturna work similarly to ARB?
I don't.
Renin inhibitor.
Yeah, I don't know. What I'm trying to look for it here. Oh, you're talking about the repurposing ARB,
Right.
telmisartan?
I think,
well.
Yeah, no, this is this one up here.
Sorry.
Tecturna, Atherosclerotic.
Okay, yeah. So I don't know, and in fact, I really have never. It looks familiar. I've seen it somewhere. I think that's one of those ones to look up and find out.
Okay. So Steve Hartman has here some articles on telmisartan for cardiac protection. That's what these are here.
Yeah. Also, fat mobilization helps them lose fat.
Okay.
The which one? The Atherosclerotic?
No, telmisartan.
Oh, okay. And that's causing weight loss just simply because of the reduction in inflammation and oxidative stress, or maybe it's the effect
to
on.
Actually be a decent treatment for non-alcoholic fatty liver disease. It helps mobilize visceral fat. But besides that, I started using it on all my guys on gear. My theory is that these guys who are on gear and training hard, they're growing muscle, but they're also growing heart muscle, and we want to prevent that. And telmisartan specifically seems to prevent this cardiac remodeling.
So you're using it in high performance athletes? Is that?
Yes.
Okay. Yeah, I mean, and I wonder if it has to do with the adiponectin that maybe, and I should have, I didn't think to look into it, but I still get fuzzy with adiponectin exactly, but it was linked to at least in the slideshow, linked to better glucose metabolism, insulin sensitivity, I believe. I'm not sure, but I'm sure that might be the reason for the connected to the weight loss, because otherwise I don't really see exactly why. I mean, besides reduction in inflammation and oxidative stress in general. But again, one of those things to take a second look at and look up and get a clear understanding. Yeah, that's a good one. Yeah, you have an interesting population. Weren't you doing a lot of function like detoxing, like different modalities as far as
Oh, yeah.
cryotherapy or?
Yeah, no, I see them all. There's nothing I don't do. But I do see a decent amount of, or occasionally like crazy bodybuilder on a bunch of gear. And my job is to make sure they don't kill themselves. They're not going to stop what they're doing, but I have to try to
Sure.
guide them, make sure they do it safely.
And you're in Florida, like what part? Like
Melbourne.
Melbourne. Oh, okay. You're right up there with Dr. Beamer then, close by.
Yep. Oh yeah, he's
Okay. Yeah. Are you still seeing, you had a patient before that had more like Lyme, like it sounded like they were more like somebody with like heavy metal toxicity and Lyme and mold. Was that you just happen to get one of those patients, or do you see those patients as well?
No, not so much Lyme. I see the vaccine injured and the lung haulers though.
Okay, so some of the modalities you have, do you have like do you have hyperbaric?
I'm looking at buying that. I'm going to install some cool stuff this year in my office.
Yeah, I mean, now I had a colleague when I went to the A4M conference a few weeks ago. There was a naturopath out of Washington State who very passionate and knowledgeable. Who said he was having success with combining hyperbaric, ozone, repeated therapies in getting rid of chronic fatigue. And it really does make sense. I did the hyperbaric training. It's like an extra, day before the conference, a full day of training on hyperbaric. And I see hyperbaric as very, very relevant. And the reason is it can reverse immunosuppression, bone marrow suppression.
Uh-huh.
And it seems like the lymphopenia that people are getting may be the result of bone marrow suppression, or partly the result of bone marrow suppression. And the logic is that there's an article that COVID and chemotherapy have very similar properties. And chemotherapy is well known to cause immunosuppression. The problem is when you have immunosuppression, it stays. Okay, and that was the basis of another lecture I did. And we're not talking about progenitor cells, which is, just think of the family of immune cells and red cells and T cells and B cells and all those precursor cells. We're talking about the hematopoietic stem cell, the one that's in the most quiescent state that needs to keep reproducing, producing a daughter cell and a progenitor cell, and the daughter cell and the progenitor cell, because that's how we just continue to live. If that's not replicating, you're running on borrowed time. And so you may not know that you're immunosuppressed. Okay. And I can say this because when I had a lymphocyte map done, after about 4 months after having the first Omicron, don't quote me on that, because it may have been after the second Omicron, but I think it was after the first Omicron, which was not a big deal. I mean, Omicron wasn't that sick, but my lymphocyte map, I mean, I had severe lymphopenia. My CD4 count was extremely low. I mean, it looked like somebody with AIDS. And I've got no problem saying it because it is what it is. But that's scary. My lymphocytes were like 1,000 something. Yeah, I was at the level where, if I needed surgery, they probably wouldn't have done surgery. It doesn't make sense. I consider myself to be a healthy person, but I did have severe post-COVID fatigue. I mean, I didn't have the first COVID, but it obviously got into my system. And later I found out I'm genetically prone to have the fatigue because of my genetic susceptibility to inflammation and difficulty in detoxifying, which means that I need to address those issues. Okay. Again, knowing what I'm doing and not just guessing. But if my lymphopenia was coming from immunosuppression, bone marrow suppression, then there's only a few things that are going to reboot that. Peptides aren't going to do it. And fasting for 48 hours, that's one that I found in the literature, 48 hours or longer. And it has to do with, you're really flipping the switch from AMPK or mTOR, AMPK, those sort of yin yangs. You have to go into AMPK and shut off insulin-like growth factor, which is really what's taking it into the activating mTOR. You got to go into healing and regeneration versus growth and proliferation for a long enough time to produce enough stress to be able to reach the hematopoietic stem cells, because they're in such a quiescent state. They're hard to reach. It's hard to promote enough stress to activate them. And by fasting long enough, it will be starved of insulin-like growth factor long enough that it will flip, it will switch, it will go into healing and regeneration. And then when you finally eat, it will turn on into growth and proliferation. Hyperbaric does the same thing. And it's because it's creating enough stress, enough of an oxidative burst by sort of pushing the oxygen into the mitochondria. It's kind of like pushing turbo boost on a sports car. And by boosting the mitochondria, you're able to, well, you're actually producing oxidative stress. I mean, but you're producing a burst of oxidative stress, because I mean, mitochondria, even though you're optimizing it and you're, think about the car, when you all of a sudden slam the gas down and open up the air valve, you're going to have a lot more, you're going to have a burst. And it's that burst that's able to, again, stimulate the hematopoietic stem cell, activate it, because it needs enough stress to flip a switch and turn it back on. And then you can combine fasting with hyperbaric, and then according to this professional in Washington State, he is having results by adding the ozone to it, and I believe that's also adding an oxidative burst. In fact, even getting out of the hyperbaric chamber is another oxidative burst. And so it's really all about the burst, and it's really all about flipping switches. And at the basic level, it's all about flipping switches between AMPK and mTOR, because on a basic biological level, we're either in growth and proliferation or we're in healing and regeneration. The problem is we're in growth and proliferation too much because we're unhealthy Americans, unless we do restrictive eating and only eat 8 hours a day and fast for 16 hours, which is what I do now. Or like if the athletes, those high performance athletes we talked about, they are exercising so much and so intensely that they're essentially doing the same thing. But everything is about flipping those switches, and those switches require a burst. And so that's another sort of rule of thumb I've started to realize. And so even if we're bringing in all the right nutrients, and we're taking the appropriate peptides, because we know the pathway, there still needs to be some sort of activation mechanism, a spark of some sort. And so that's where these modalities, or I'm sure even cryotherapy, that's sort of a burst. Ozone gives you that burst because it's got that extra free radical. Hyperbaric, because you're going into turbo boost. Fasting, exercising is a burst. And so that's the lens I look through when I think of, okay, how am I going to get from here to there? And I've got the pathways covered. Now I've got to have I got to turn the ignition on. So I hope that's what I've concluded so far, tying in all of the other, why this or why, and not just thinking of just one thing. It's not like everything's all about ozone or it's all about, no, these things all have their place. And ozone has its place because it's probably it's anti-infectivity, that free radical that, has a direct effect on maybe some of the chronic pathogens that are part of the problem as well. And so that's the thinking process. Yeah. And then Dr. Dan, you had said, gear. You had asked, by the way, thanks. You had said something about gear. What does gear mean?
Yeah, that was my comment. Yeah, so as Ronnie Coleman would say, just the basics, right? So you got your 500 of test, you got your DECA, you got your HGH, maybe use some equipoise, maybe Masterone. These guys are throwing the kitchen sink at their bodies.
But gear literally stands for.
That's just what the bodybuilders call it.
Oh, okay. Oh yeah, I got my gear. All right, I got my goods.
They're like, you see a guy at the gym and it's like, oh, he's on gear.
Okay, because he looks like Arnold Schwarzenegger or something.
They don't even look like that anymore. They're bigger than that.
Oh my, Arnold's nothing. That's old school, huh?
Yeah, it's not good.
No, it makes sense. Well, I feel pretty good about tonight. Any other questions?
Yeah, I'm ready to go.
All right. Well, thanks, guys.
Thank you.
Thanks for having me. And yeah,
Okay.
I'm happy to do more of these. If they create some ahas. So
Okay, we'll have you back. The vitamin D is calling.
Okay. All right. Sounds great.
Next week we have Nima. What's her last name? She's from Augurex, Augurex. They do autoimmune testing. So she's going to show us some autoimmune. We had a gal from another outfit a couple of months ago. So what's going on here? Can we close that out somehow? So
okay.
Let's stop that there. Yeah, okay.
All right.
So a gal named Nina Murazi, that's her name. And she'll be talking about some autoimmune testing next week.
Okay.
Sounds
great.
So, that's next week, and in 2 weeks, just to give you a little heads up, we have I think we have Felice Gersh again. Everybody knows her. She's our hormone gal. And I know with Dr. Pam Smith is coming up, and Dr. Andrew Campbell's coming back also in the next few weeks. So we have a pretty good lineup. Pass it on to your crew there, Dr. Joseph, and great as always. Thank you.
Sounds great.
John, got
Awesome.
anything to add in?
All's wonderful and good.
Okay. Again, everybody, thank you. Hope you all had a good holiday season. And anybody else has anything they ever want to present, Ron, if you would like to present something again, let me know. Dr. Dayton, Dr. Cruz, Dr. Nario, and maybe Dr. Mulho can, since she teaches at the medical school, physical diagnosis, we can go back to that, since most, I don't know, I forgot most of it. I'm pretty sure. So, okay. Any questions, anybody? Everything will be up on our website as usual, aosrd.org/webinars.
Awesome.
/webinars. And thank you so much. And we'll be in touch. See you
Awesome.
all next week, same time, same station.
Awesome. Awesome. Good night.
Good night.
Thank you.